Good afternoon, everybody, and I'd like to take this opportunity to thank Marty McCulloch for inviting me to participate in this meeting. So for the next few minutes or so, I'm going to talk to you about how we differentiate aortic stenosis from mitral regurgitation. I have no disclosures to announce. As most of you would be aware, the American Society of Echo and also the European Association of Echo have published guidelines for the way we should assess valvular stenosis. Many of you will know that the ASE booth downstairs are actually giving away free CDs with all these guidelines on there, so if you haven't got one, grab one of those. So basically we're going to look at some of these guidelines. So before we talk about how we differentiate AS from MR, we just need to cover some basic concepts about aortic stenosis. Now, from these guidelines, it has been stated that echocardiography has become the means for evaluation of aortic stenosis severity, and cardiac catheterisation is no longer recommended. So essentially, echo is the gold standard for the way we assess patients with aortic stenosis. Now, these are also from the guidelines, basically looking at the quantification or how we determine severity of aortic valve stenosis. The important thing to note is that the velocity is crucial to ensuring that we actually get accurate measurements. So these recommendations and these cutoff values that we use rely on the accurate aortic velocity measurements that we obtain via echocardiography. So for this reason, it's important that we use multiple acoustic windows to assess for aortic stenosis, and these windows that routinely should be examined in any patients with aortic stenosis and also prosthetic aortic valves include interrogation from the apex, suprasternal window, right supraclavicular window, right sternal edge, and very rarely you can get signals from the subcostal window depending on the angle of direction. So here's our set of images. So we've got here traces from the apex, right supraclavicular, right suprasternal notch and the right sternal edge. Now the guidelines say that we should use the velocities from the window that provides the highest signal. So the highest velocity obtained from any window is reported and used in the calculations for aortic valve area. So in this example, this would be from the apical window. And the lower values from other windows are ignored. So we're only averaging velocities from the window that provides the highest signals. When obtaining these signals, it's important that we use the PEDOF probe. And this is the non-imaging blind CW probe that we use. And this should be differentiated from the PEDHOF probe. Now, one of the advantages of using the non-imaging CW probe is that it has higher signal-to-noise ratio, so basically you can get better signals without being contaminated by background noise. It has better access to small intercostal spaces and therefore is very useful for obtaining signals from right sternal edge, supraclavicular fossa and so forth. And also it does not bias the observer to 2D images. Because this is a blind CW probe, we are only looking for signals based on their Doppler quality, audio signal and so forth. So we're not biased by looking for signals from images that we obtain good 2D images from. Because it is a blind probe, however, it's important to note that sometimes we can get confused with our signals, and so this brings me to the main point of this topic, which is differentiating aortic stenosis from mitral regurgitation. So why can this be a problem? Well, if we look at the apical view here, this is an apical 5-chamber view with colour flow Doppler imaging. We've got a wide colour Doppler box. So what we can appreciate is we've got mitral regurgitation, and this patient also has aortic stenosis. So the problem is when we're trying to obtain AS signals and MR signals is that both of these signals occur during ventricular systole. Both are directed away from the transducer. And in the case when you've got significant aortic stenosis, both are going to be relatively high in velocity. So this is one of the problems that we have. So in this example here, so we're not sure if this is aortic stenosis, this is mitral regurgitation and so forth. So we're going to look at how we can identify these. I'm sorry, that slide's gone a bit wonky there. So how do we differentiate aortic stenosis from an MR jet using non-imaging CW? There are 4 things to look at. We can look at the shape of the signal, we can look at the duration of the signal, we can look for diastolic signals, and we can also look at the velocity of the signal. So we'll go through each of these in turn. So we'll start off by looking at the shape of the signal. So remember, with mitral regurgitation, this is going to tell us the pressure gradient between the left ventricle and the left atrium during ventricular systole. So essentially what we can see is that the velocity is relatively high throughout most of the systolic period, and as a result we have this parabolic shaped signal which peaks in mid to late systole. With aortic stenosis, This will tell us the pressure gradient between the left ventricle and the aorta during ventricular systole. And if we look at our pressure curves here, we can see that the gradient will be highest usually around early systole. And this is reflected on our Doppler trace. So what we can see is that we have a early peaking signal. So the signal shape is more of a V-shaped signal. A couple of things to remember, however, though, is if you have a patient who has got acute severe mitral regurgitation, instead of having a parabolic late peaking MR signal, what we can have in fact is a V-shaped signal which peaks in early systole, and this would look similar to what we see with the aortic stenosis signal. So this type of signal occurs when we have acute severe mitral regurgitation because there is a marked rise in the V-wave pressure on the atrial pressure trace. So as we can appreciate, the pressure gradient then between the left ventricle and the left atrium decreases towards the end of ventricular systole, and as a result we have this V, what's referred to as a V cutoff sign of our mitral regurgitation signal. Likewise, in patients who have super severe aortic valve stenosis, instead of having a V-shaped signal, they can have a more of a parabolic shaped signal which can peak in more towards mid-systole. And again, this is because when we have very severe aortic stenosis, we get this flattening appearance of our pressure waveform in the aorta, and as a result we can appreciate that the pressure gradient throughout systole is maintained relatively high throughout the whole of the systolic period, and as a result we get this more parabolic shaped signal as shown here. So let's now look at duration of signals and how this can help us. So remember, what we've got to consider first is what's going on in the cardiac cycle. So this is our left ventricular pressure trace, our aortic pressure trace, and our left atrial pressure trace. When the mitral valve closes, you can see here, this is where aortic valve closes, and the period between mitral valve closure and aortic valve opening is referred to as the isovolumic contraction time. This is where the aortic valve closes, and this is where the mitral valve closes. And the period between aortic valve closure and mitral valve opening is referred to as the isovolumic relaxation time. With aortic stenosis, the signal occurs between aortic valve opening and aortic valve closure only. So it will be this duration. Whereas with mitral regurgitation is going to occur from mitral valve closure to mitral valve opening. So this is going to encompass isovolumic contraction time and isovolumic relaxation time. So as a result, the mitral regurgitation signal will always be longer than the aortic stenosis signal. So if we look at these traces here, this is our aortic stenosis signal and this is our mitral regurgitation signal, and we've measured the time durations here. This is 258 and 385. So remember that mitral regurgitation will always be longer than the aortic stenosis signal. And I'll just pinch this quote that I heard Peggy Knowles say yesterday, that remember, leaks last longer, and I thought that was a good thing to remember, to help you remember that. The other thing that we can look at is look at the diastolic signals. So in this example here, we've got mitral inflow and a systolic signal, mitral inflow and a systolic signal, mitral inflow and a systolic signal, mitral inflow and a systolic signal. One of these is aortic stenosis and one of them is mitral regurgitation. And if we pay particular interest on the time intervals, so what we can appreciate here is our mitral inflow. We have a little break here, then we have a signal here. We have a little break here, then mitral begins, and then we have a little break here again. So this signal is in fact aortic stenosis. So we can see here there's these intervals between isovolumic contraction time, isovolumic relaxation time. And if we look at this signal, we can see that there's continuity now between mitral inflow, systolic signal, continuity between this systolic signal and mitral inflow, and so forth. So this is aortic stenosis and this is mitral regurgitation. So the key with identifying aortic stenosis and mitral regurgitation is you've really got to get both jets. So the key is you've got to show aortic stenosis and mitral regurgitation signal and then look at these various factors to work out which one is which. So now let's look at measuring the velocity of the signals and how this can help. So if we look again at our pressure traces here, so aortic pressure trace, left ventricular pressure trace and our left atrial pressure trace. Remember, as I already mentioned, the aortic stenosis gradient is between the left ventricle and the aorta during systole, and our mitral regurgitation occurs during the pressure gradient between the left ventricle and the left atrium. So we can appreciate that the MR gradient is always going to be higher than the AS gradient. So this means then that the MR velocity will always be greater than the AS velocity. So as I mentioned, MR gradient is greater than AS, and so MR velocity will be greater than the AS velocity. So in this example here, so this is from the same patient, so we've got AS signal and the MR signal here. So this is aortic stenosis because it's less, and then this one is mitral regurgitation. Now, one of the other interesting things that we can do when we've got a patient who's got mitral regurgitation is we can use the mitral regurgitation signal to help us cross-check our aortic stenosis signal. This is particularly useful in patients who have hypertrophic obstructive cardiomyopathy as well. So if you've got mitral regurgitation, remember that the mitral regurgitation velocity using 4V squared will tell us the pressure difference between the left ventricle in systole and the left atrial pressure. So if we can measure what the MR velocity is, and if we can estimate what the left atrial pressure is, we can then rearrange this equation to calculate the left ventricular systolic pressure. Most times we tend to estimate left atrial pressure, say, about being 10. So all you need to do is measure the peak MR velocity and estimate your left atrial pressure. We can then work out what the left ventricular systolic pressure is. So we can do that, so we know what our left ventricular systolic pressure is. If we then measure the patient's arm blood pressure, we can then work out the pressure difference between the left ventricle and the arm, and this will give us an idea of the pressure gradient across the aortic valve or across the left ventricular outflow tract. So that's the one way we can do this when we've got mitral regurgitation. It's important to note, though, if we do this measurement, this will correspond to what's referred to as the peak-to-peak gradient that we measure on cardiac catheterization. So what we're measuring is the left ventricular systolic pressure, and we're measuring the aortic blood pressure at this point in time. So this correlates to the peak-to-peak gradient. And what we can appreciate is that these peaks do not occur at the same point in the cardiac cycle. So what you can see here is that this gradient will be a little bit lower. What we measure on Doppler echocardiography is the maximum instantaneous pressure gradient. So on Doppler, when we're usually doing our aortic stenosis gradient, what we're measuring is the maximum Doppler gradient between the left ventricle at peak systole and the aortic pressure at that particular point in time. So remember, if we do that previous equation as I showed you, what we were measuring is the peak-to-peak gradient, which is not the same as the maximum instantaneous pressure gradient. But it's just one way of helping you cross-check the outflow tract obstruction. So in summary, the way we can identify or differentiate aortic stenosis from mitral regurgitation, remember we look at the shape of the signal. So remember, in aortic stenosis, most commonly it peaks in early systole and it's V-shaped, with the exception in critical aortic stenosis when it tends to be more rounded in shape. The mitral regurgitation signal will peak in mid to late systole and will be parabolic in shape, again with the exception of patients who have acute severe mitral regurgitation. Remember, we look at the durations of the signal. So if you've got two signals away from the zero baseline, you're not sure which one is AS and which one is MR, remember that the AS signal is not as long as the mitral regurgitation signal. So remember, leaks last longer, whereas the MR signal will be greater than the AS signal because it includes isovolumic contraction time and isovolumic relaxation time. Look for diastolic signals, so this can be helpful, but if you've got an aortic stenosis signal and mitral inflow signal, which you can sometimes see, there will be gaps between the mitral inflow signal and the aortic stenosis signal, particularly during the isovolumic relaxation period. So if you've got MR that is not continuous with the AS signal, then this is going to be your AS jet. If you've got the the mitral inflow signal which is continuous with the MR signal, then this is going to be mitral regurgitation. So that's what we look for. And also remember with velocity, so if you've got two jets, the highest one is going to be mitral regurgitation and the lower one is going to be aortic valve stenosis. Now some people might say, oh, if you look from other windows, then you can cross-check that it's aortic stenosis. But we've actually picked up mitral regurgitation from the right sternal edge. So just because you're getting a signal from supraclavicular fossa or right sternal edge and it's towards the transducer and it's systolic, don't just always assume that that is aortic stenosis, because you can get mitral regurgitation from those windows as well. Remember, it's heading in the same direction. Also remember, if you do have mitral regurgitation, you can use this to cross-check your pressure gradient across the outflow tract. But remember, this is going to be equivalent to the peak-to-peak gradient across the aortic valve or left ventricular outflow tract. And in particular, I find this quite useful for checking patients who've got hypertrophic obstructive cardiomyopathy when you can't get really good signals and you've got nice mitral regurgitation. And I thank you for your attention. Thank you.